Perceive, process, perform. Do you need inspiration for your practice, or do you simply need to practice inspiration? With this series, we aim to do both. Give us 15 minutes and we'll give you practice inspiration.
My name is Bill Robbins and I'm a restorative dentist in San Antonio. And today, my practice inspiration for you is going to be the Study Club treatment planning session. Obviously, treatment planning is the key, the heart and the soul of the Seattle Study Club system, and we all enjoy the treatment planning sessions in our study clubs. I've had the opportunity to facilitate a lot of treatment planning sessions, and so what I'm going to share with you today is my idea of a perfect treatment planning session. There are a couple of requirements that I bring to a treatment planning session. The first is related to photography. It's obviously impossible to do good treatment planning sessions without excellent photography. And the second requirement is that we have to have a systematic way of looking at the patient's face. For me, that's the global diagnosis system, and that's the one I'm going to share with you today. And the global diagnosis system tells us where we should put the teeth and gingiva in the patient's face. The second thing that will be presented are the regional diagnoses. Regional diagnoses are all of those parts of the diagnostic system that we've always gathered. That's the pulp testing and the perio charting and so on. The next part is that it's very important that we do all of the diagnoses before we start the treatment planning. I found along the way that very commonly in study clubs, they jump right into the treatment planning without getting the diagnoses correct first. The next is to the presenter, and that is he or she must not be so invested in their treatment plan that they're not open to the criticism. And obviously it should be constructive criticism, and so the last rule is everybody has to be nice. All right, so let's go through a treatment plan with Oscar. First of all, we're going to do the traditional things we always do. We're going to talk about the social history, and you can see it there. We're going to talk about the medical history. Oscar is a healthy guy. He reports no medications, and he has no drug allergies. We're going to talk about the dental history. He doesn't have much of a dental history. He's had a little bit of dentistry done in Mexico. He knows that he grinds his teeth, but he's never worn a nighttime appliance. His chief complaints were basically that his teeth are getting shorter, and it concerns him both from a health point of view and also from an aesthetic point of view. So these are Oscar's treatment goals. He wants to stop the wear of his teeth, number one. Number two, he wants his smile improved. And number three, he wants to do this in as conservative as a manner as he can. He listens to what I say, but he lets me know initially that he doesn't want more than he needs. So where do we start on Oscar? We always start our treatment planning by looking at the face first. And there are two photographs that are the most important. First is the full smile photograph, and the second is the repose photograph. So when Oscar is in full smile, we can see that he shows less than all of his front teeth, even in a full high E position. And when he's in repose, not only does he not show any of his maxillary incisors, but in fact, they're 2 millimeters up underneath the lip. He's -2. So there are the two most important photographs, the full smile and the repose. So what else do we need to know about Oscar? Well, in our treatment planning system that Jeff and I teach, we have what we call the 5 questions. And in order to make a global diagnosis on a patient, you have to ask and answer these 5 questions. And those are the normal numbers on the right. We ask about face height, lip length and mobility, the gingival line in relation to horizon, the tooth length of the maxillary anterior teeth, and can you feel the CEJ and the sulcus? So let's answer the 5 questions on Oscar. So we measure the mid-face and the lower face, and it's 65 and 71. That's an outlier. It should be 1:1. We measure the upper lip. It's 22 millimeters. That's normal. We measure the mobility of the lip from repose to full smile. That's 6 millimeters. That's also normal. We look at the gingival line from canine to canine on both the upper and lower arches, and we can see that it's concave. That's not the way it's supposed to be. It's supposed to be straight. We measure the maxillary central incisor, and it's only 7 millimeters long, and we remember it should be 10 to 11. And finally, we feel for the CEJ and the sulcus, and we can't feel it. So now we have the answers to the 5 questions. We now move on to the regional diagnoses, that's traditional data that we've always collected. Oscar has pathologic wear on his upper and lower anterior teeth and also his lower molars. We can see it there and in the posterior teeth. He has minimal wear, interestingly enough, on the maxillary posterior teeth. Oscar has erosion on the lower molars. He has inadequate clinical crown height on the lower molars because of the attrition and the erosion. You can see that the gingiva is right at the marginal ridge on number 18 and 31. He has a defective restoration on tooth number 19, we can see radiographically. He's got early interproximal caries. Once again, we can see radiographically. He's got crowding of his lower anterior teeth, and he's skeletally class 1. He's got hyperkeratosis and pigmentation in his lower lip. And he reports snoring at night. Those are the regional data that are important to us. The next thing we're going to do is a risk assessment. And the reason it's important to do a risk assessment is because that which has happened in the past is a good predictor of what's probably going to happen to our dentistry in the future. So we're going to look at 4 areas. The first is biomechanical, and his risk is high. Biomechanical is looking at attrition, erosion, and caries in the large restorations that Oscar already brings to us. The next risk assessment is functional, and once again, he is a high risk functionally because of his parafunction. We then look at the periodontal risk, and it's low. Oscar doesn't have any periodontal disease. And finally, dentofacial is a fancy way of saying aesthetic, and I would put Oscar at a moderate risk for aesthetics. So at this point, we've gathered all of the global data, we've gathered all of the regional data, and it's now time for the participants in the treatment planning session to break up into groups and to go into their treatment planning sessions. So we're going to leave these slides up on the screen so they still have the information that I've shared with them. And now I'm going to ask them to do 2 things. I'm going to ask them, first of all, to create a problem list, and secondly, a sequenced treatment plan. So they're going to have their 15, 20, 30 minutes, however long the decision is that they need to make their treatment plan. We're then going to come back together as a group, and each of the different tables are going to discuss their treatment plans based on what they decided in their groups. Okay, once that's complete, now it's the presenter's turn to finalize the treatment planning session and show his or her treatment plan that they've developed. So once again, where do we start? We always start by looking at the face and answering the 5 questions. And when we look at the answers to the 5 questions on Oscar, we can see that the lip length and mobility were normal. So we can take that one away, and that leaves us with 3 possible global diagnoses. The first is a long lower third of the face. The second is dentoalveolar extrusion with wear of the teeth. And the third is altered passive eruption. So let's look at those 3 global diagnoses on Oscar. The classic finding in the VME patient is, first of all, a long face, and secondly, a gummy smile and full smile. So the question is, does Oscar look VME? And the answer is obviously no, he doesn't. So Oscar is not VME. The next diagnosis is dentoalveolar wear or dentoalveolar extrusion with wear. Does he have a concave gingival line and wear? Yes, he does. He also has wear and erosion on the posterior teeth. So yes, Oscar has dentoalveolar extrusion with wear both in his maxillary mandibular incisors and his lower molars. The third diagnosis is altered passive eruption. His teeth are short by measurement, and we cannot feel the CJ and the sulcus, so does Oscar have altered passive eruption? And the answer is yes, he does have altered passive eruption, but does it matter? And the answer is no, it really doesn't matter, because in his full smile, we can't see the gingival line. So we only have one global diagnosis that's going to impact our treatment plan, and that's dentoalveolar extrusion with wear of his maxillary and mandibular incisors and his lower molars. It turns out that in the global diagnosis system, there are only 3 primary treatment options for dentoalveolar extrusion. The first is orthodontic intrusion and flaring. The second is functional crown lengthening. And the third is increasing the patient's vertical dimension. So let's look at those 3 in Oscar. Is there a place for orthodontic intrusion and flaring in Oscar? And the answer is obviously yes. That's the major way we're going to treat Oscar. Is there a place for functional crown lengthening in Oscar? And the answer is once again yes, because the clinical crowns on his lower molars are too short. The third is vertical dimension. Is there a place to increase vertical dimension in Oscar's treatment plan? And the answer is yes. So that's what's cool about Oscar's a treatment planning patient. We can incorporate all three of the primary treatment options in one patient. So I asked the people in the groups, treatment planning groups, to make a problem list, and so now I'm going to show mine. And you can see it. I don't need to read it. It goes from caries all the way down to the bottom, which is crowding of the lower incisors. Once the problem list has been created, then we make a treatment plan. The treatment plan consists of caries control and oral hygiene instruction, counseling him on skin protection for his lips, referral to a sleep physician to rule out sleep-disordered breathing, functional crown lengthening of his lower molars, increasing vertical dimension by adding composite to his lower molars prior to the orthodontics. Once the orthodontics has started and the teeth are somewhat aligned, then we're going to do intermediate composite bonding to make the teeth anatomically correct. We're then going to intrude and flare the maxillary anterior teeth. We're going to align the lower anterior teeth, and then we're going to do porcelain veneers on the uppers and porcelain and gold crowns on the lower posteriors. And then ultimately we're going to give him either a night guard or some other treatment for his sleep disordered breathing. Okay, that's the end of the day. It's important when we do treatment planning sessions not to turn them into case presentation sessions. So we never show treatment the day we do treatment planning. However, we can come back in the future and have another wonderful session which we're going to call case presentation evening, not treatment planning. So obviously we would start out the evening with the photos that we showed before. We would then go over the treatment plan that we had proposed 1 or 2 years before, and then we would start to show how the case went. So we'll briefly do that with Oscar. So we're going to increase Oscar's vertical dimension by using a leaf gauge and adding composite to his lower molars. You can see that composite's been added to the occlusal surfaces on the 4 lower molars. We now have more space in the anterior for our bonding. So our orthodontist is now going to intrude and flare the maxillary anterior teeth, and you can see that the gingival line is now level on the maxillary anterior teeth. We're then going to do the intermediate bonding with composite to make the teeth anatomically correct. And this will then direct the orthodontist to complete the case with the teeth in the perfect position for the final restorations. So all the orthodontist has to do now is get good coupling in the anterior teeth and get the posterior occlusal plane aligned, and the ortho is complete. So here's Oscar after the appliances have been removed, and we can see that the diagnostic bonding has directed the teeth into the correct position. This is after we've removed the composite to show where the teeth were before and now that they're ready for the restorations. And once again, they are in exactly the correct positions to receive the porcelain veneers. This is after the veneers have been placed. And that's a before and after the veneers. And we can see that we've gone from 7 to 10 millimeters in length, which was a goal. And we now have a smile that's much more aesthetic and pleasing than before. And in the posterior part of the mouth, the wonderful thing about this treatment is that remember we added composite to the occlusal surfaces of the molars. And once the case was complete, we removed the composite, and that became the occlusal reduction for our crowns in the posterior. So it makes it a much more conservative way to treat this patient in the posterior part of his mouth. So what's the last step on Oscar's case? Well, in Oscar's case, the last step was to get a sleep study done. But the reason it was the last step instead of the first step is because when I was treating Oscar, my consciousness to the need to pay attention to sleep disordered breathing was just being aroused. And so when I started Oscar, I didn't really think about ordering a sleep study and didn't know until the end of treatment that it was something I should have done at the start. So at the end of the treatment, we ordered a sleep study, and in fact, Oscar does have moderate obstructive sleep apnea. So that turned out to be a very important part of Oscar's treatment. So there's Oscar 5 years post-op after the final restorations have been placed. He has retention in the teeth that were moved orthodontically, permanent retention, not removable. There he is before and after with a smile. And the last step in the case presentation is to discuss where we had problems in the case and where we had to deviate from the treatment plan. And the primary issue for me and Oscar was not a problem or a deviation. it was ignorance. Ignorance of the idea that I needed to do the referral to the sleep physician before we started the case. So that's my template for a good evening or a good day of treatment planning, and I hope that this inspiration has been good for you and it will be helpful in your study clubs. Thank you.